From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Monica Gandhi, who's an infectious diseases specialist and Professor of Medicine at the University of California, San Francisco. Welcome, Dr. Gandhi, to this JAMA Clinical Reviews podcast.
Thank you.
So to begin with, what is PrEP? Why is it important, and who should receive it?
So PrEP, or Preexposure Prophylaxis, is important because right now in the world we have 1.3 million new infections with HIV every year. That was the statistic in the last UN AIDS report of 2024, which means we are definitely not preventing HIV at the rates that we would like to, given that we have highly effective medications to prevent HIV. PrEP should really be given to anyone who's at risk for HIV infection. This is men, women, anyone who has had a sexually transmitted infection over the last year, anyone who states that they're at risk or asks for PrEP, or anyone who uses injection drugs or has sex with more than one partner that's new, really should be qualifying for PrEP.
Excellent. Now, what are the different therapies available for PrEP? How well do they work? And what are some of the advantages and disadvantages of each?
So at this point, there are actually now oral and injectable forms of PrEP. The oral form of PrEP that's the most commonly used is a combination of tenofovir disoproxil fumarate and emtricitabine, and I'll abbreviate that as TDF-FTC. Daily oral TDF-FTC is actually the most well-studied PrEP regimen there is and the most widely available PrEP regimen there is. It's one pill once a day, has been studied in men, women, and works in both cases. The original efficacy trials, that was essentially the IPREC study, which is the first study that was done of oral TDF-FTC, showed only about a 44% efficacy, but that rose if we proved essentially that drug-taking behavior was around 4 or more pills a week. And it can rise up to about 92 to even 96% effective if there's almost daily oral pill taking. In both men and women, at least 4 doses a week is the most effective way to take daily oral TDF-FTC. There's also a regimen of tenofovir alafenamide plus that FTC or TAF-FTC. Daily oral TAF-FTC has actually only been studied in men who have sex with men and transgender women in the Discover study. And then there's a third agent, which is an intramuscular agent called cabotegravir. That's given once every 8 weeks, and that's been studied in men who have sex with men, transgender women, and cisgender women in 2 studies called HPTN 084 and 083. Those 2 studies showed really high efficacy of intramuscular cabotegravir every 8 weeks. It was actually superior to daily oral TDF-FTC in both men and women, and that's a shot given every 8 weeks. Importantly, that drug is not as accessible or not as widespread as we would have hoped. And then finally, there's just been 2 big studies of an agent called lenacapavir. Lenacapavir is an injectable agent that's so potent, it's given once every 6 months. The Purpose 1 trial was just published in July of 2024 that showed really high efficacy of lenacapavir, actually 100% efficacy in this trial of preventing HIV among cisgender women. And the Purpose 2 trial, the press release was just on September 12th, 2024, that showed 96% efficacy in lenacapavir preventing HIV infection among men who have sex with men and transgender women. That study, that last one, the Purpose 1 study among cisgender women, also looked at TAF-FTC among women. It's the first time that that's ever been looked at. Did show efficacy, but not as good as we had hoped. and that really was related to adherence, because one big issue with oral ART or antiretroviral therapy for PrEP is that you really do have to adhere to it, either the pills or the injectable, to have full efficacy to prevent HIV.
And there was another medication you mentioned in your article called the monthly vaginal dapivirine ring. I'm not sure I'm pronouncing that right. Could you talk
Yes.
about that a little bit?
Yes. So there is one final option. This is only for cisgender women because this is a vaginal ring. It's called the dapivirine ring, and this is self-inserted. It's a monthly ring that has a medication in it that elutes over time and protects women from HIV. Now, the monthly dapivirine ring is not as widespread as those other agents that we just talked about because it has not been approved by the FDA for use in women in the United States. It has been approved by the European Medicines Agency and by the World Health Organization. And the monthly dapivirine ring is good because some women prefer this form of HIV prevention. What we've really seen across everything that we've talked about is that giving populations choice does increase the uptake of biomedical prevention. There was just a large study that was not in the article, but just recently got published in Lancet HIV from what's called the Search Group in Kenya and Uganda that showed that if you have daily oral TDF-FTC, but you add on another choice, in that case it was intramuscular cabotegravir every 8 weeks, biomedical prevention coverage increased by at least 50%. What this means is we hope we have a choice of products for people who they can choose between the ring for women. They can choose between the intramuscular cabotegravir every 8 weeks, the subcutaneous lenacapavir every 6 months when that becomes available, or the oral tenofovir-based options. And the hope is, and this is really a big message of the article and a big message in the HIV community, is we want accessibility. We want access of all these PrEP agents for populations across the world. We're not quite there. We definitely want to get there, especially with the injectable agents.
Certainly. Now, you've really emphasized the importance of adherence to PrEP. What are some strategies that can be used to increase adherence?
So that's exactly it, that we really do need at least 4 doses a week of the daily oral TDF-FTC for it to work properly. That's both in men, as shown in a study called iPrexolay, and then a really nice article published in JAMA in 2024 by Jeannie Marazzo et al. That shows that even among women, it really is 4 doses or more per week. So to get women and men and anyone who needs PrEP to take the pill on a regular basis, there's been a number of different strategies to try to increase adherence to PrEP. One is, for example, adherence clubs or peer support or SMS text messaging to remind people or pillbox reminders. One recent study that our group conducted actually was using what's called a urine tenofovir assay. This was just published this summer of 2024. And what this urine tenofovir assay does is it says yes, no. It shows you just like a urine pregnancy test if you've taken the tenofovir or not. A line that shows that you've taken it versus not taking it. And then by counseling individuals around that test, saying, great job, keep it up if you're taking it, or how can I help you get the medication in your system if the urine tenofovir test is negative, that counseling can improve long-term adherence. And we're really looking for scalable adherence interventions to help increase that pill taking, because these shots are not available everywhere. They're not yet at all. Lenacapavir isn't yet approved. This is a brand new medication. And right now we have more widespread accessibility of daily oral TDF-FTC. It's actually free in most countries that use PrEP.
Excellent. Now, in your article, you talk about on-demand PrEP. What is that?
So on-demand PrEP, though it hasn't completely been presented to the FDA and it hasn't been yet endorsed by the CDC, is actually a very powerful strategy, and many practitioners are using it. And the idea of on-demand PrEP is to take the TDF-FTC around the time of the risk exposure. The actual strategy is called 2-1-1, which means 2 pills of the oral TDF-FTC before the risk exposure, before the sexual exposure, for example, and then 1 pill within 24 hours after, and 1 pill again within 48 hours after that exposure. That on-demand TDF-FTC has actually only been studied in men who have sex with men and transgender women. It's not a strategy that has been studied among cisgender women. So it's really endorsed for non-vaginal sex, and it can be useful for people who are more planning, who, for example, there's risk exposures only on the weekend and can plan around that event. It's more useful for planned risk and planned sexual exposure than more spontaneous risk.
Terrific. That's really helpful. Now, my last question is there anything else that generalists should know about PrEP that we haven't covered?
Yes, there is something that I really want to stress, which is that at this point, really PrEP, part of the reason that we have not had widespread use of PrEP to the degree that we'd like is that it's not being widely prescribed by primary care providers, by urgent care providers, by those who are working in the emergency room. But really, we would get greater uptake if we have more widespread prescribing by general internists. If we think about contraception, at the beginning when it was first released, it was more prescribed, for example, by OBGYNs. Then we got widespread prescribing by primary care providers. We're really in the era now, and this is a strategy endorsed by the U.S. Preventative Task Force, that we should be in a widespread way having internists prescribe PrEP. It's really easy to prescribe. Daily oral TDF-FTC just needs to be accompanied by HIV testing regularly, along with sexually transmitted infection testing, and some monitoring for creatinine or renal issues, because TDF-FTC can be associated with some renal and bone loss. That really just needs to be done every 3 months, the HIV testing every 3 months if there's ongoing risk, and then regular every 6-month creatinine monitoring. If you use intramuscular cabotegravir, which is the more widely available here in the US, that's once every 8 weeks. It just requires HIV testing along with it to ensure that you're giving it in the face of still living without HIV. So really easy to give. I'm hoping that this piece, among others, will really increase general internist prescribing of pre-exposure prophylaxis.
And even beyond general internists, would you say it should be our family medicine colleagues and the nurse practitioners that practice side by side with us in primary care?
Yes, totally agree. All healthcare professionals. And remember the urgent care healthcare professional, because that's a good time that people can come in for sexually transmitted infection testing, and even in the emergency room to just assess and go ahead and prescribe PrEP.
Absolutely. Well, thank you so much. I'm Dr. Karen Lasser. I've been speaking today with Dr. Monica Gandhi from University of California, San Francisco, about PrEP for HIV. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technology.